Recently, during a encounter with a company representative and one of my colleagues, we were talking about how small tip or how smaller diameter tip, which affects ultimately the incision size in phacoemulsification, should be used, and what are the advantages of using a smaller incision. So I came up with my thought process and I done some research, and with some evidence I am presenting my thoughts with you all, and I hope that this would be a useful discussion which would throw some light on the practices and the pattern of the phaco incision which we all are using. So common sense says that a smaller incision may be preferable, and the reasons may be that this will cause a faster healing because, as we can understand, a large incision will take more anabolic activity to let the incision heal. The self-sealing incisions are dependent on the size of the incision. A longer incision will mean a lack of sealability, and this is so important for tissues which are thin like cornea. Then we have another issue which is astigmatism. So whenever we make an incision on the limbus, it is going to, or clear cornea, it is going to relax that meridian and make it relatively flat. So this will cause a difference in the curvature between the two meridian, and it may increase or decrease the pre-existing astigmatism. So looking at these issues, a smaller incision may be preferable. However, there are some limitations of a small incision which we'll just see. So small incision means a smaller tip which has a smaller bore, so the slow tissue removal. So in phacoemulsification, we are ultimately removing a tissue after emulsifying it, and smaller is the bore, the lower is the tissue removal rate. So that means that there will be a longer surgical time, and that also means that ultrasound energy will be dissipated more, so there is going to be some collateral damage which will be greater in a small incision, and there will be increased heating because the fluid which goes in and the content which come out, it is something which has a cooling effect on the temperature caused by the ultrasound friction with the sleeve, and this may be also incompatible to the IOL size or injector, so that this may cause some damage to the incision, or one may have to resort to increasing the incision size. Then a smaller tip is more likely to get choked. So when you have hard cataracts which have leathery and brown and black pigment, they are likely to choke the tip, and as a result you will have to stop during your surgery to release the choke or the clog. So these are the limitations of a small incision. If any one of us can have something else to be added, do mention. So what are the available options when we want to have an incision size decision for phacoemulsification? So this is something like we have converted the phaco tip size in gauge, which is the needle tip size, and this is converted into diameter in millimeters and a corresponding incision size. Mind it that usually the incision size is not dependent on the needle tip size, but rather on the sleeve. So we have a standard which is 2.7 to 3 mm incision size, and then we have co-MICS, coaxial microincision cataract surgery, which will have something like 2.2 millimeters. And this will also mean that there will be a difference of 0.2 millimeters between the tip sizes. And if we just imagine 0.2 millimeter, we'll realize how much difference are we talking about. And so, what is the evidence based medicine? So, this is all a thought process, a hypothesis, but ultimately, when put to field test, what are the outcomes? So, I've seen two preview papers which will include number of other papers, and they have concluded. This is one from Cochrane Library, and they answer these questions: that is smaller incision better in terms of astigmatism, visual outcomes, and endothelial safety. And the review article, the author has concluded that there's hardly any difference in the incision size related astigmatism when we are talking about incision size of 1.5 millimeter to 3 millimeters. Visual outcomes are nearly same, and also that the endothelial safety is also same. So it doesn't make a difference in a term that if we are looking at the advantages of a small incision, there are none when compared to a incision which is standard size of 2.8 mm to 3 mm. If we look at the problems which may be caused by the incision size or smaller incision, there are several, and this is another review paper which talks about these issues, and it says that smaller incisions have ultimately an inadvertent enlargement of the wound because of the IUL delivery systems and the manipulation during the surgery. The 1.8 mm incisions had a higher endothelial misalignment and gaping, resulting in ingress of trypan blue. So this was one study which was done at the end of the surgery. Trypan blue dye was instilled in the conjunctival sac, and then the fluid was aspirated and looked for any presence of quantification of trypan blue dye. And it concluded that these small incisions may actually remain gaping and leak fluid, and not only leak fluid from inside out but can also aspirate the fluid from the conjunctival sac, which is imaginable situation for onset of endophthalmitis. And the study also has concluded by looking at other studies that there's a greater incidence of endothelial cell loss and also Descemet's membrane detachment when we are talking about smaller incisions, something like 1.8 or sub 2 mm incisions. So presently 2.8 mm Phaco incision size using a 2.0 mm sleeve and a flare 19 gauge tip is efficient, fast, and at par with 2.2 mm incision Phaco when we consider the advantages. And the IOL which can be delivered through a sub 2 mm incision are limited in number, as we all have seen, and hence the incision may need to be enlarged. So ultimately the patient doesn't get anything out of these small incision surgeries. More so if we look at it, it is 2.8 versus 2.2, which is 0.6 millimeters of difference, which we can imagine is not so significant. And as I have just shown, the evidence also concludes that the patient or the clinical situation doesn't gain anything. So let's reconsider whether moving to a smaller incision in present day technology and advancement which is available to us, is it worth it? Thank you.